panel. Oh, it's over here. Yes, it's over here.
Can you hear me?
Yeah.
Oh,
A little quiet. Try that. Okay, tell us now.
can you hear me?
Yes. Good.
Oh, good. Okay. I was wondering if there's a problem on my end.
All right, good morning. We are live. This is Senate Health and Welfare. It's Thursday, February 6th. And today will feel like a lighter day, although we're still doing some pretty important work as usual. We're looking at S36 with Ledge Council, and then we'll have some committee discussion. We'll take a break, and then we're going to be hearing from the University of Vermont Health Network CEO and one of the vice presidents in charge of quality. So we'll start with S36, and I will give a quick background for the bill, and then Katie can go through it with us. So the quick background is that there's a group of folks working on, as you know, there are a lot of people working on mental health issues and on recovery services for folks with mental health or co-occurring disorders, substance use disorders. And one of the groups includes Federal Judge Rice and the Federal Defender General and Department of Health folks and others. And during the conversation, one of the issues that's come up about recovery is that when people go into recovery they may go in for 30 days, and it may be insufficient to help them get to a place where they can live outside. And so what has happened, and this is in particular in Valley Vista, for example, people are treated, they leave, and then they come back. And so what this bill is attempting to do is to add some coverage for Medicaid patients who need a little more time for recovery. It may not solve the whole problem, but it's a step forward, and it's what we can hear testimony about it and why it's necessary.
For years, the 30 days was frequently not enough time.
Yeah, that's really the issue that we've been hearing about.
For most of the time, Valley Vista and Bradford, for instance, was only 14 days.
Yeah.
And then you'd have to lobby for 30 days. And I lobbied with them for 60 days with my daughter.
Wow.
She came out good. And then 11 months later, she passes because she was on Suboxone and they kept her thirsty. She couldn't get to the clinic she went to the clinic that day, it was closed. And so she went to a friend's and got opiates.
That's sad.
It was laced with fentanyl.
Yeah, not sad.
Killed her and her baby.
So this has some real meaning for folks. I mean, sometimes, we look at policy and it's way up there, but ultimately it's how it helps people. And that's really what we're about. So Katie, can you walk us through? And I think there's some issues in here around Medicaid coverage and so on. And so take your time in explaining. We have a good chunk of time this morning to look at it, as long as your time is also.
Sure. Good morning, Katie McLinn, Office of Legislative Counsel. I will share my screen and pull up the draft. Here we go. Okay. So we're looking at S36 this morning, and this bill is focused on a population of individuals who have co-occurring conditions, substance use disorder and a co-occurring mental health condition. And these are individuals who are also Medicaid beneficiaries. So this is directing the agency to provide longer stretches of coverage for long-term residential treatment of this population of individuals. So in Title 33 in our Medicaid chapter, we're adding a new section. I'm going to go slowly because I know there are new members and I know you've already been marking up a bill with Jen. But this language right here shows us that we are making an amendment in the Green Books, language that will be codified and easy to find on an ongoing basis in the future. And then in subsection A, we have language that directs the Agency of Human Services to provide coverage for medically necessary long-term residential treatment to Medicaid beneficiaries with the co-occurring substance use disorder and mental health conditions when the long-term residential treatment is prescribed by a healthcare professional who is practicing within their scope of their professional license. And the residential treatment program is also participating in Vermont's Medicaid program. And then we have language that coverage provided under this section shall not be less than 30 days if the beneficiary's substance use disorder can be successfully addressed with MOUD, medication for opioid use disorder. Previously, that was medication assisted treatment. So those terms have been updated throughout the Green Books, changing medication assisted treatment to MOUD. And then the coverage under this section shall not be less than 60 days if the beneficiary's substance use disorder cannot be successfully addressed by medication for opioid use disorder. And then in section 2, this is a technical change. We're just renumbering sections in the existing chapter so that language is grouped together within the chapter. And the effective date is July 1, 2025. I did reach out to AHS yesterday and they were very kind to get me a very quick answer because I wanted to better understand what the limits were like currently.
What was like? I didn't hear that.
The day limits were like for
Okay,
reimbursement. And it sounds like they don't have a set number of days that they will cover for. They call it an episodic rate so that they will pay by somebody's stay. But they have built their rates and models to assume that there's on average a 14-day stay. And so that is what sort of the midpoint is for people who are staying with long-term residential care. I might just read what they wrote because I think it is more succinct
can you
than
do
me
that? Yeah.
summarizing it. Yep.
You get tied up with days pretty quickly.
Yep. So this is from the email from AHS. There is no limit on the length of time, but there is also no additional reimbursement beyond the episodic rate for a single continuous stay. The episodic rates were modeled to reflect a roughly 14-day stay on average. The idea with any bundled payment is that the rate is set at the midpoint, and you might have members who utilize less than the rate covers and members who utilize more than the rate covers. Members can be readmitted anytime after 3 days and receive a new episodic payment should the member relapse and need to return to this level of care. Treatment facilities make the determination of when the appropriate time to discharge the member is. So they're saying it's a medical decision to discharge the member versus a coverage decision.
So Katie, is this information something that we can have post, or don't have to post the full email, but the letter itself?
Yeah, I mean, I could pull out the relevant paragraph.
Yes.
I'm wondering if AHS would want to put something more formal together if they know it's going to be posted on your website. I could.
Well,
reach
let's not, let's hold the posting for now because we will have them in to testify, but
Okay.
if we could just look at that, maybe send it to Kiki and then we'll figure out how to get a copy of it to each of the committee members so we can look at it and understand a little bit of what AHS will be presenting.
Okay, I can do that.
Yeah. Wait, I agree with you. We don't want to post it yet because AHS should have an opportunity to give their full testimony.
Yeah,
Yeah.
we'll be taking it out of context.
Yeah, we don't want to take it out. Yeah, thank you, so. So it's not clear. Can you put that into plain language for us?
Yeah, so what they're saying is that they are not setting a rate in terms of a particular number of days per se. What they are doing is they're paying per somebody's they call it the episode, but like per their stay at a long-term residential care facility. And so their information is that the average stay is roughly about 14 days. But some individuals who are using the service are staying less than 14 days, some are staying more. So the rate is based on the stay itself and not the number of days of the stay. And I think they're assuming that it'll sort of average out with between the folks who are staying longer and those folks who are staying shorter. They're also saying that after somebody's discharged, a new episode, a new episodic rate, or a new stay is another way of saying that, can begin again after 3 days of being discharged. So one stay could have been completed, and then 3 days later, the person continues to need care, they can be readmitted, and that is a new charge for a new stay. And then again, the language that I took from this email is important, is that it is not the Medicaid program that is deciding when a person should leave. It is the long-term care facility, the health care, the long-term residential facility, is making the determination as to when it is, medically appropriate to discharge the patient.
So it's the counselor or the physician or the clinical decision as to whether or not the patient should be discharged.
Whoever the medical professional is, yes.
Yeah. Okay,
But
it's always more complicated than this little bill would suggest.
yeah, if they
Mm.
might be able to keep one person 60 days, but if they keep two or three, they're gonna lose money if they're being paid for 14 days.
Yes. Yes,
That's how it's a bundled rate. So they're getting a bundle, but if they start keeping people longer, they're going to lose that money. And I doubt they're working on a really wide margin.
so, so that's on the Medicaid side, so the payment, and then the residential care facility. So the question is, what's the difference between a short-term and a long-term residential care facility? Do we know what facilities are being affected by this?
I didn't ask that question, so I
Okay,
think,
so the recovery centers, so there's a lot going on right now. We're getting a big report back from the group, including Department of Health, on recovery centers. We're getting that in the fall. We
Mhm.
worked hard on that last year with S-186. So now the question is, who's affected by this? So Senator Cummings has pointed out that the care facilities might be losing money if something doesn't happen, right? So, all right. We have a lot of testimony to get on this. But Katie, do you have any sense of what the distinction is between what the care facilities would be eligible for this? Who's eligible for this type of reimbursement? Who's providing the treatment and then making the decision that people would come back after 3 days, be readmitted? Because that's the problem, the revolving door issue is what we're trying to solve.
yeah, it's whoever the medical professional is that is working at the long-term care residence.
Okay, I guess my question is, can you tell us the difference between a long-term care facility? What are the long-term care facilities we're talking about? What are the facilities that would be treating these people and then have some eligibility? So we got
Are you
residential-
asking, I don't have a specific list of names of the facilities throughout the state that are meeting the status as a long-term care residence. I think that would be something for the department or the agency to come and bring to you.
That's good. We'll do that. And I know, of course, then we have a place like Jenna's Promise, which is different. I mean, it's a long-term residential care facility, and the patients are actually, there's money involved, they're paying. It's almost a tuition thing, but they're also working. So that's a whole nother layer. I don't know how that relates. We're gonna have to dive back into this again, understand. Senator, go ahead.
I was just gonna say I would also like to see a list of the long-term residential treatment facilities and the ones that take Medicaid, because
Yeah.
this is, and which ones don't take Medicaid. Now I'm just very curious what we have in the state. So
Yeah.
get a report on that.
That's good. And that is the report that's coming in.
And-
But you're right. We would need to see where we are with it. Yeah. Did you have a question?
I was just in my facility direction.
Yeah. The Medicaid.
Yeah.
Yeah. Yeah, so and then, I don't know how far down this reaches in terms of kids. So Mark Redmond has been very much involved with this from Spectrum, doing a lot of work, and then and then expanded up to St. Albans, so there's a facility up there. Okay. Katie, can you do us one more favor, because we have time to do this today?
Mhm.
Can we walk through the bill slowly? And then what I'm gonna ask of the committee is, as we walk through the bill slowly, think of the questions, think of who you would like to have in for testimony. And then the questions that you might want to ask, and you can write those down, but if there's an area of concern, let me know. I've already started doing that, but. So go ahead and walk us through one more time, please. Great.
Sure. So we're adding a new section that directs the Agency of Human Services to provide coverage for medically necessary long-term treatment. And I'll pause there and say one of your questions might be, how do you distinguish between long-term residential treatment, short-term residential treatment, and recovery residences? I've heard all of those terms thrown out, and they have distinct meanings. So you might want to get clarity as to what this particular type of treatment is as compared to the others, and where there are Medicaid providers throughout the state. This coverage, as I said, would be for Medicaid beneficiaries with substance use disorder and a co-occurring mental health condition.
Hang
We're
on.
long- Yep.
Yeah. Go ahead. So.
Okay, so this is for medically necessary treatment. So who is making the decision? Somebody at the facility, but who is that? You might want to
Yeah,
dive into that.
those are good. Yeah, so medically necessary, that's a consistent term that we see in statute, isn't it?
It is. Mhm.
Yeah, okay, and so we'll ask that when we get folks in, right?
Mhm.
That is, okay.
Okay, so these are folks with co-occurring conditions. And they're also a population for whom long-term residential treatment has been prescribed by a healthcare professional who is practicing within the scope of the professional's license.
So,
And,
go ahead.
oh, I was going to just say, and the program also has to be participating in Medicaid. So that goes back to the question that was asked, who is participating?
Okay, but it could be two different professionals that we're seeing here.
I would suspect, well, I guess it could be. You have a professional who is making a decision about whether this type of care is medically necessary. That could be somebody out in the community, that could be somebody at the facility themselves who are making the decision that this treatment and this setting is medically necessary and appropriate.
Yeah.
If the original decision is made in the community, it might be a different provider within the facility who's making a decision about the medical necessity of discharging a patient. So you may have more than one medical professional making decisions about this
I guess overall, how is the decision made? You know, if we're seeing people going in and out. Senator Douglas, go ahead.
Thank you, Madam Chair. So the way that I read it is, the person that determines if it's medically necessary is the healthcare professional that's prescribing such residential treatment. That's the way I read it, at least.
Yeah. And well, so what we're saying is is it someone in the residential facility or is it someone from the outside who is then recommend this person go into the facility?
Well, if there's a person prescribing it, then presumably that professional will think it's medically necessary.
Hopefully, yeah. Yeah, no, with you. So what, but these are questions we want to ask. I want to make sure we have clarity.
That's how I would assume whoever you're seeing in the community prescribes that you go to residential treatment. I would presume that there is a medical professional within the facility
Mhm.
that decides to get discharged.
Yeah.
And that's
That's the one, right?
that's where the conflict comes, especially if your payment system is set up on the assumption that most people will stay 14 days. So the exception, for everyone that stays 30, somebody's got to stay 1 or 2, which probably doesn't happen. If we bump that to 60, I'm not sure what that would do.
And another thing I'll say is often people with mental health issues, they'll have case managers and they'll have a whole treatment team surrounding them. So it's not just one person that makes decisions. I think in most cases there will be one person who is ultimately making those decisions, but usually the collective decisions made by a group of people are surrounding the case manager and the client.
And that's exactly the kind of question that we want to get. We want an answer. We want to know how that's happening. We don't want it to be made based on only financial loss or gain. Okay. We want to make sure the person's cared for. But you're right. And then how is it made, whether it's at Diva or whether it's at a facility?
So what problem are we trying to solve with this bill? Is there a problem with the 30 days?
The problem we're trying to solve is the revolving door
Okay,
that allows, that when people are discharged, then they're turning around and coming back.
that's,
And the readmission is within, if it's a 3-day turnaround. So you suppose you're there for 14 days or
they're out for 3.
then they say, oh, you're fine to go. And then you go, you're back in the same environment you were before.
Well, we've set up a payment system that encourages that.
Yes, and we don't want the recovery center or residential recovery facility to be disadvantaged
Right.
because patient needs to be there longer, but they're not being paid for it.
Right.
Yeah. Okay. Okay. Keep going, Katie.
Sure. I was just gonna say, if I may, as I listen to your conversation, I think the question that you're all circling around is the 14-day average that the episodic rate based on, is that clinically best practice? Is that the clinical best practice? Is 14
That's good. Thank you.
Yeah.
Or should the average that's built into the episodic rate be a different number to better reflect clinical necessity? Is that helpful?
Yeah, that really articulates it well. Thank you.
Okay. And then I'll just move to the subsection B again. This bill proposes that coverage provided under this section not be less than 30 days if the beneficiary substance use disorder can be successfully addressed by medication for opioid use disorder, and not less than 60 days if the beneficiary substance use disorder cannot be successfully addressed by medication for opioid use disorder.
Okay, so then the question that kind of weaves through all of this, and it relates to what you were saying about the 14-day episodic day period being best practice. What rules or criteria are being used? And so I hope we'll hear it's clinical, but interpretive. But how's all this being determined? I guess question.
Well, the other thing is Senator Hart, that his daughter went to the clinic and it was closed.
Yes.
So what does that system look like?
Is there a hotline?
When we started here, we had to drive to Massachusetts until somebody died
Exactly.
on the trip.
Then it was 2 hours from the Northeast Kingdom to Burlington and back every day.
Yeah,
Yeah.
and this person was going from the Kingdom, I think it was Newport to
Mhm.
Massachusetts. And then coming back here and working on it.
Mhm.
And you could only get 1 day's
Worth.
worth at a time, and then we've changed that. It might be helpful to find out where we are in hub and spoke. I mean, where are the clinics?
We'll do that.
Yeah.
I mean, we
What
obviously,
happens if do I only get 1 day, and if something happens and I don't get to the clinic the next day, am I back out on the street? You know, what are we doing to make sure that we put you in for 14 days, you're medically now on a medical treatment, but if you don't get that every day, then, you know, we need to make sure that they have access to the medication.
so we're hearing that this is expanding the scope of what we're looking
Yeah,
at, but
but it's
it's
part of
certainly
it.
relative to it. I'm thinking the question here is if it was a residential care facility that the person is going to and it's locked after hours, I mean, what availability is there to get back in touch with the clinician, the counselor, whomever? And then the question is, if it's not the res facility, is it the clinical access at the hub and spoke?
Yeah.
And then what does 988 have to do with this? So we're gonna have to ask
It should
AHS
be a
to-
wrap, it was supposed to be a wraparound
It has to
system.
be wraparound for these folks.
It was a clinic that she went to and it was just, they hadn't opened up yet. It was 10 o'clock in the morning. Usually they're open at 8.
But they weren't open till 10.
They weren't open. She was there at 9:45. Who's Vincent DeLucy?
He's he's one of my predecessors.
Can we do that's a little.
That's a loaded question.
Yes.
He just sent me a friend request.
Okay,
Yeah,
but
legend
we'll have a
in this
conversation,
building.
Senator, when we are offline. All right, so thank you for that question.
Does he
Okay.
work for the NEA or the SEA?
Yes.
Yeah.
Yes.
He's in the building. We'll introduce you.
Okay, so, we've been through this. Can we summarize a little bit about what we know about the bill, just the kind of the umbrella summary? Katie, do you want to do that? And then we'll
Sure,
Take
I'm happy to.
Yeah.
So the bill is looking at Medicaid coverage for individuals with co-occurring substance use and mental health disorders for their stay at a long-term residential facility. We have talked a bit about how AHS develops its rates, and we've talked a little bit about how the rate for the stay is considered an episodic rate. The rate building process was built around the average length of stay being 14 days, and the committee is looking to learn more about whether 14 days reflects clinical best practice or if the episodic rate could or should be readjusted around a different length of time that better serves individuals who are being served by these facilities.
Thank you. And as you're going through this, it occurs to me, it's occurred previously, but it just comes back to mind that by helping people get to a more solid place in their lives, will save money overall. So instead of continuing to go through the process again and again and again, if we extended that time, and we'll have to hear from clinical folks about this, we could be saving money and saving lives in a better way. So, Thank you. Questions for Katie on this? All right, we're good. So Katie, and suggestion, we'll put this on the agenda and we'll try and get it on with some testimony. Perhaps as early as next week, and have you come in. So Kiki will be in touch on that.
Sounds good. Thank you.
All right, good. Thank you very much for being here this morning.
You're welcome.
All right, so committee, our morning is pretty light today. We do have some procedural things that we can talk about. We're gonna take a break until 10 o'clock. And then when we come back, I think it'd be helpful to talk for a little bit, maybe come back at 10:15. I don't want to interrupt us altogether. Let's come back at 10:15. We have some time. And our goal then will be just to talk a little bit about the information that we heard yesterday from the two, from the group and the two, which I thought was really informative and helpful. And it should resonate with some of the other things that we've been hearing about. So Charlotte,